So the most common abnormality we see in intravenous urogram is the calculus. It's important to identify the calculus on a plain film because after we give contrast, the contrast may obscure the calculus and it may go missed. So the other abnormalities we look for in a SCOUT film are abnormal calcifications, which can be either parenchymal or soft tissue calcifications. We have to look for abnormal air foci, and we are supposed to have a look at the bowel gas for to assess the preparation for intravenous urogram and other pathologies like soft tissue mass or a skeletal abnormality. So coming to the most common pathology, which is the renal calculus. So 70% of the urinary tract calculi are radiodense, and they can be easily identified on a SCOUT film. So this, sir, is my pointer visible?
Yes, visible.
Yeah. This radiodense opacity, this is SCOUT film showing a radiodense opacity in the lower pole of the left renal shadow. This is suggestive of a renal calculus. So sometimes the stones can be radiolucent and they can be missed on a SCOUT film. So how do these radiolucent calculi appear? They appear as a filling defect on delayed phases. So this 5-minute pyelogram image showing the bilateral pelvic calyceal systems. We can see the dense opacifications of the calyces here. And so here we see two tiny filling defects in the lower pole calyces of the left kidney. So this is suggestive of a radiolucent calculus. So coming to the next morphology, which is the Staghorn calculus. A Staghorn calculus is a calculus which involves the renal pelvis and extends to at least two calyces. So in this SCOUT image, we see a calculus which is large calculus which is completely occupying the left renal pelvis and is extending to the upper pole calyces. This is suggestive of a Staghorn calculus. So, not all radio opacities we see on a plain SCOUT film are renal calculi. We have to be aware of some of the common mimics of urinary tract stones. So the common things which can mimic upper urinary tract stones are gallbladder stone or calcified lymph node. So here we see a well-defined calcific ovoid opacity, which is superimposed on the right renal shadow, and this is nothing but a calcified gallbladder stone. So how will you differentiate this? By we'll have to do a lateral imaging or oblique imaging to identify the exact position of the gallbladder stone. So common pathologies which can mimic lower urinary tract stones are vascular phleboliths, calcifications of the prostate or ovarian dermoid. So in this image, in this plain image, we see multiple calcifications, and we can see a central lucency within these calcifications. This is suggestive of phleboliths. And in case of phleboliths, most of them will be situated below the level of the ischial spine. So we have to be aware of these mimics before reporting it as a calculus in IVU. So we should not jump on and say that all radiodense calculi are renal calculi in IVU. So coming to the abnormal calcifications, it can be either medullary or cortical calcifications. So most of the calcifications are medullary because of the concentrating effects of the nephron. And so in this image, we see multiple bilateral calcifications of the renal pyramids. These are nothing but this is a classical picture of medullary nephrocalcinosis. This can be seen in the common causes of which are hyperparathyroidism, renal tubular acidosis, and medullary sponge kidney. So cortical calcifications is relatively rare, and it can be seen as a sequelae of acute cortical necrosis. Here we see a rim of calcifications along the outer cortex of the right kidney. This is suggestive of which is typical of a cortical nephrocalcinosis. So coming to the abnormalities of renal size. So as discussed previously, the normal renal size is 9 to 13 centimeter in the craniocaudal dimension. On an IVU image, this is roughly equal to the size of 3 to 4 lumbar vertebra. So here we see on this image a normal size left kidney, but a small and shrunken right kidney. So significant discrepancy is right kidney more than 1.5 centimeter than the left, and left kidney more than 2 centimeter than the right. So coming to the abnormalities of renal contour. So interpapillary, we have to assess the interpapillary line. Interpapillary line is nothing but as the name suggests, it's a line connecting the tips of the papilla. So here we see the red line, which is the interpapillary line connecting the tips of the papilla. And normally the outer corneal cortex should be parallel to the interpapillary line. So any alteration in this is suggestive of a pathology. So the average parenchymal thickness is slightly more in the polar regions compared to the interpolar regions. So in the polar regions, the parenchymal thickness is 3 to 3.5 centimeter, and whereas in the interpolar regions, it's 2 to 2.5 centimeter. So any decrease in parenchymal thickness, any alteration in parenchymal thickness, we should assess further. So in this image, in this pilogram image, we see that there is a decreased parenchymal thickness in the polar regions, in the lower pole of the right kidney, as annotated here. So here we see that the calyces are somewhat distorted in the lower pole compared to that of the upper pole. This is a classical picture of chronic pyelonephritis. So we see increased parenchymal thickness in is typical of mass lesions or tumors, or benign. It can be even seen in benign tumors like simple renal cysts. So it's important to distinguish between a normal and abnormal. Normal pathology is fetal lobulations, and abnormal pathology like infarct. So both of them will have a indentation on the outer renal contour. In the case of fetal lobulation, the indentation is shallow. The indentation of the renal contour is shallow, and it's between the renal papillae. Whereas in case of infarct, the maximum indentation of the renal contour is just opposite to the calyx. And also we see the normal parenchymal thickness in case of a fetal lobulation, whereas in case of an infarct or a scar due to chronic pyelonephritis, there will be a significant decrease in the renal parenchymal thickness. Coming to the renal axis and position, as we know, the vertical axis, craniocaudal axis of the kidney is parallel to the upper margin of the iliopsoas muscle. So any causes of altered renal axis and position can be any retroperitoneal mass, which is displacing the kidney, or it can be due to congenital abnormalities like abnormalities of position, fusion, and malrotation, which will be discussed in the further slides. So coming to the abnormal renal position, renal ectopia, it's nothing but the abnormal location of the kidneys. So it can be either simple or crossed ectopia. Simple ectopia is when it is located on the same side of the ureter. Crossed ectopia is when the kidney is located on the opposite side of the ureter. So in this image, we see a simple renal ectopia where the left kidney is situated in the lower position. This is because of the failure of ascent of the left kidney to the lumbar region from the pelvis. So here we see a caudally positioned left nephrogram in the pelvis. This is suggestive of simple renal ectopia. Whereas in the crossed renal ectopia, both the kidneys are on the same side. The ureter of the right kidney normally opens in an orthotopic position, whereas the left ureter crosses the midline to insert on the left BUG. So this is an image of crossed ectopia. Often the kidney will be fused. This is and is described as cross-fused renal ectopia. So coming to abnormalities of renal fusion, this was discussed in the previous session. So horseshoe kidneys, fusion of the kidneys at the lower pole, and pancake kidneys, complete fusion of all the poles of the kidney. And such a kidney is usually in the will be placed in the pelvis. So this is an image showing an abnormal renal axis. What we see here is the lower poles of the kidneys are fused and they are oriented towards the midline, meaning that the axis of the kidney is altered. The craniocaudal axis of the kidney is not parallel to the iliopsoas muscle. This is because of the fusion, and both the kidneys are directed medially towards the spine. So coming to the nephrogram, a nephrogram is nothing but the radiographic image of the renal parenchyma. So what we see in nephrogram is that the density of the nephrogram should be bilaterally symmetrical, and they must be of equal density. For a normal nephrogram, three things are required. One is the adequate blood flow to the kidney, and second important parameter is the normal excretory function of the kidney without obstruction, and the third parameter is the normal venous outflow. So whenever we don't see a nephrogram, we should take into consideration that some technical factors like insufficient dose of contrast or extravasation of contrast. So some pathological conditions which can cause an absent nephrogram are end-stage kidney disease, absence of kidney, post-nephrectomy, and renal ectopia. So on a 5-minute image, the nephrogram should be receding. So this is a 5-minute image showing that the nephrogram and the contrast in the renal parenchyma and the collecting system are of equal density. So on what happens on a 10-minute image is the most of the contrast is excreted from the parenchyma into the collecting system. So on a 10-minute image, the pyelogram is predominantly seen, meaning that the contrast in the collecting system should be more than the contrast in the renal parenchyma. So some causes of abnormal increased nephrogram can be classified into immediate dense persistent nephrogram, increasingly dense persistent nephrogram, or an inhomogeneous spotted nephrogram. So coming to increasingly dense nephrogram, the nephrogram is initially faint. So on a 10-minute image, what we see is the right-sided nephrogram is seen. On a 4 hours image, there is progressive increase in density of the nephrogram compared to that of a 10-minute image. Normally, the nephrogram should fade over the course of 5 minutes. So this happens due to acute ureteric obstruction, renal vein thrombosis, and acute glomerulonephritis. So what happens is, because of the ureteric obstruction, the contrast is there is a delayed tubular transit of contrast, and there is a high pressure building within the renal pelvis. So this results in the back pressure is transmitted to the renal parenchyma, and this results in a persistent increasingly dense nephrogram. So immediate dense persistent nephrogram, as the name suggests, the nephrogram is initially dense on a 10-minute image, and in a series of images repeated at 6 hours and 12 hours, the density persists without fading. So there's no decrease in density of the nephrogram. So normally the nephrogram should decrease in density as the contrast is getting excreted into the collecting system. So here what it happens is, in cases of acute tubular necrosis, the glomerular filtration is happening, but since the tubules are leaky and damaged, contrast is not getting excreted into the tubules and it stays within the glomeruli. So what we see is persistently dense nephrogram, which is not excreting into the collecting system. So we don't see any opacification of the pelvic axial system even up to 12 hours. So this immediate dense persistent nephrogram can be seen in acute pyelonephritis, acute tubular necrosis. Bilaterally, if it is seen, we should think of hypotension. So this happens due to uninterrupted glomerular filtration, but since the tubules are damaged, the contrast is not excreted into the collecting system. So coming to spotted nephrogram, it's an inhomogeneous nephrogram. What we see is multiple areas of non-opacifications of the renal parenchyma with areas of preserved perfusion. This can be seen in small vessel vasculitis, where there are areas of decreased blood flow. In those areas, there will be non-enhancement. So the areas of preserved enhancement take up the contrast and so the nephrogram will be inhomogeneous or spotted. So commonly it is seen in polyarteritis nodosa and scleroderma. Moving on to renal artery stenosis. So what we see here is in renal artery stenosis is that, so we see a normal size left kidney, whereas the right kidney is contracted. We see that its height is less than 3 lumbar vertebra and with a smooth outline. So this is a minute nephrogram, and this is a 15-minute this is a IV image taken at 15 minutes. So what we see here is the nephrogram is becoming increasingly dense. So adequate blood flow is needed for a normal nephrogram. So what happens here is the nephrogram becomes increasingly dense, and there's delayed functioning of the kidneys. So what we see here is the delayed pyelogram. The left kidney has excreted most of its contrast and it has become less dense, whereas the pyelogram is on the right side is becoming increasingly dense. You can see the dense contrast in the right collecting system compared to the left. So this finding can be seen in renal artery stenosis. Moving on to renal papillary necrosis, it's nothing but the necrosis and sloughing of the papilla. So what happens is there is a formation of cavity in the papilla which communicates with the collecting system and gets filled with contrast. So here we see small cavities in the papilla which communicate with the collecting system and it gets filled with contrast. So these are the papillary. This is suggestive of papillary necrosis. The common causes of papillary necrosis are diabetes, sickle cell anemia, and analgesic nephropathy, and other causes like pyelonephritis. So here we see a normal papilla, and here we see a swelling of the papilla, and here we see there is partial necrosis and filling of contrast in the center of the papilla, and here we see a complete papillary necrosis. So hydronephrosis, whenever we see hydronephrosis, whenever we see the dilatation of the pelvic calyceal system, we should mention the grade of hydronephrosis in the report. So this is a normal pelvic calyceal system showing that the normal size pelvis and normal calyces. Grade 1 hydronephrosis is nothing but dilatation of only the renal pelvis, but the calyces are maintained. So in grade 2 hydronephrosis, there is dilatation of both the pelvis and the calyces. In grade 3 hydronephrosis, there is a dilatation of the pelvis. There is moderate dilatation of the renal pelvic calyceal system, and there is blunting of the calyces. So here we see that there is flattening of the papillary impressions. So in this grade 1, we see a normal papillary impression on the calyx. But in case of grade 3, there is flattening of the papillary impressions because of the blunted calyces. So as the hydronephrosis progresses, there is ballooning of the calyces, and so the calyces gets significantly dilated. And so what happens is that the papillary impressions are lost. Here we don't see any papillary impressions in a grade 4 hydronephrosis. So this is a picture showing a grade 4 hydronephrosis. What we see here is a significant dilatation of the pelvis and the calyces, and we see a loss of papillary impressions. So moving on to obstructive pathologies, which is a PUJ obstruction. So there is marked dilatation of the renal pelvis and calyces. So what we see is a box-shaped pelvis and with a sharp narrowing at the pelviureteric junction. So we don't see any opacification of the ureter in a PUJ obstruction. So this is a serial set of images of PUJ obstruction. So what we see here is a progressive dilatation of the renal pelvis. So compared to the 5 minutes image, the 30 minutes image, in the 30 minutes image, there is a significant dilatation of the renal pelvis, and so the contrast is not excreted into the ureter. So this is a right PUJ obstruction with the non-functioning of the right kidney. So coming to the role of diuretic urogram, it's useful to identify an intermittent obstruction. So what happens is the patient can come with intermittent colicky pain, and due to intermittent obstruction, normal standard IVU can be normal. So this is a patient whose IVU is normal. Whereas after we give a IV furosemide, this brings out an intermittent obstruction. This is because PUJ is non-obstructive during normal flow rates, but it becomes obstructive after when the flow rate is high. So after a diuretic is given, what happens is the contrast gets collected in the renal pelvis and the collecting systems, and so there is buildup of pressure within the renal pelvis. So this brings out an obstruction, intermittent obstruction. Since there is increase in pressure, the patient will have a severe pain during the procedure. So if the patient develops pain and distension of the pelvic calyceal system on a diuretic urography, this is suggestive of a PUJ obstruction. Now coming to some common pathologies which can be seen in IVU, renal tuberculosis. So what we see is the earliest sign in renal tuberculosis is the moth-eaten appearance of the calyces and papillary tip irregularities. So what we see here is the irregular fuzzy appearance of the lower pole calyces. We can see the upper pole calyces are well defined, whereas on the lower pole, the calyces are having an irregular and fuzzy outline. So this has been described as a moth-eaten appearance. So as the disease progresses, what we see is the formation of cavities in the papilla. So as these due to papillary necrosis, so these cavities start communicating with the collecting system, and so this has been described as a golf ball on a tee appearance. So this is a large cavity, a necrotic cavity in the papilla, which is filled with contrast because it is communicating with the collecting system. So this large papillary cavity resembles the golf ball, and this stretching and blunting of the calyces resembles the tee of the golf ball. So sometimes there can be non-visualization of a group of calyces due to stricture in the infundibulum. So as the disease progresses from the calyces from the minor calyces to the pelvis, there is formation of strictures in the infundibulum. This can result in asymmetrical calycasis, and if there is a complete stricture, there can be non-visualization of a group of contrast, non-visualization of a group of calyces. So what we see here on this image is that we don't see the middle pole renal calyces, mid-pole renal calyces. They are present, but they are not opacified with contrast because of a complete stricture in the infundibulum. So and also there is asymmetrical calycasis of the lower pole. So coming to the abnormalities of ureter, normal caliber of ureter is up to 7 mm. Any dilatation more than 7 mm is considered abnormal. So we should see the course of the ureter. Ureter is said to be laterally deviated when it is more than 1 centimeter beyond the tip of the transverse process. So we should always compare with the contralateral ureter. So some of the common causes of lateral shape of the ureter are any space occupying lesions, which can be due to iliopsoas hypertrophy, or it can be lymph nodal enlargement or a tumor. Medial deviation, the ureter is said to be medially deviated if it overlaps the ipsilateral lumbar pedicle. So there is separation of the ureters by less than 5 centimeter. Separation of the ureter from the opposite ureter by less than 5 centimeter. So the common causes of medial deviation of ureter are retroperitoneal fibrosis, retrocaval ureter, a lower pole mass in the lower pole of the left kidney, or a retroperitoneal mass which is displacing the ureter medially. So here this image is showing a retrocaval ureter, which is described as a fish hook appearance. So what happens is the ureter courses behind the IVC and then takes an abrupt medial turn and then comes to lie in front of the IVC. So this appearance is termed as a fish hook appearance, and often because of the kinking, there's dilatation of the proximal pelvic calyceal system in case of a fish hook, in case of a retrocaval ureter. So coming to duplex culling system, can be incomplete or a complete duplicating collecting system. So incomplete duplicating system is when the ureters fuse along their course. So here we see the bilateral duplex collecting systems with the two ureters which are fusing at the lower border of L3 vertebra. So this is an incomplete duplicating system. So minor form of incomplete duplicating system is a biped renal pelvis. So here we see two renal collecting systems only at the level of the renal pelvis. They are uniting at the pelviureteric junction to form a single ureter. Moving on to complete duplex culling systems, here there are two ureters which open separately into the bladder. This Weygert-Mayer's rule was discussed in the previous session. So here we see a complete duplicating collecting system. Often the upper moiety ureter ends in a uretrocele, just nothing but the dilatation of the distal end of the upper moiety ureter. So this is a complete duplicating system with the uretrocele of the upper moiety. So in case of a complete duplicating system, the upper moiety ureter is often gets obstructed and is non-functional. So this IVU appearance has been described as a drooping lily sign. So what we see here in this pyelogram image is that there is no opacification of the upper moiety ureter because it is non-functioning and obstructed. This obstructed non-functioning upper moiety, what it does is it displaces the lower moiety ureter in lower moiety system inferiorly and laterally. So this has been described as a drooping lily sign. Here we see only the opacification of the lower moiety collecting system. The upper moiety collecting system is non-functional and it's not opacified. So coming to uretrocele, uretrocele is the dilatation of the distalmost portion of the ureter. It can be simple or ectopic. Most commonly it's ectopic and is associated with the duplicating collecting system. So here we see the 15 minutes IVU image showing the dilatation of a distal portion of the ureter. So we see a thin radiolucent halo around the dilated ureter. This is described as a cobra head sign. It's the dilated ureter with a thin radiolucent halo surrounding it. So what is this thin radiolucent halo? It's nothing but the combined thickness of the ureteric wall and also there is some prolapse of the bladder mucosa. So it represents the combined thickness of the ureteric wall and the prolapsed bladder mucosa. So uretrocele should be distinguished from a pseudo-uretrocele because pseudo-uretrocele is usually congenital, pseudo-uretrocele is often acquired. So the common causes are, it can be a tumor at the ureteral orifice, or it can be edema due to an impacted stone. So when do you say it's a pseudo-uretrocele? There is an irregularity of the radiolucent halo and there is thickening of the radiolucent halo. Here we see thickening, the wall of the radiolucent halo is thickened compared to whereas in the normal uretrocele, the halo is So moving on to renal masses. So it's normally we don't do IVUs for renal masses. It has been replaced by conventional CT. But in case we do, we have to be aware. We have to raise a suspicion of. In case we see such findings on the IVU, we have to raise a suspicion for renal mass. So in a plain film, what we see is distortion of the interpapillary, as we already discussed. There will be distortion of the interpapillary line with increase in parenchymal thickness. Sometimes if the mass is very large, we can see an abnormal soft tissue mass. In case of once we give contrast, we can see a double contour of the renal parenchyma due to extension of the renal mass outside the contours of the outside the renal contours. So here in this image, we see a mass lesion in the midpole of the left kidney, which is causing distortion of the calyces. So pelvic calyceal system distortion, double contouring of the renal parenchyma should raise a suspicion of a renal mass. Moving on to the transitional cell carcinoma, it's a malignant pathology of the urothelial tract. So what we see is on IVUs, multiple filling, single or multiple filling defects in the pelvic calyceal and collecting systems. So here in this IVU image, we see multiple loosened filling defects in the pelvis, upper ureter, and the lower ureter. So this is suggestive of this is typical of a transitional cell carcinoma. So in a transitional cell carcinoma involving the pelvic calyceal system, we can see because of complete obstruction, some portion of the calyx will not take up contrast. So this is described as an amputated calyx. So here we see the calyx is abruptly terminated, and so we do not see the opacification of the upper pole calyx. This is suggestive of an amputated calyx. And sometimes the calyx can be completely distended with the tumor due to infiltration. So this is termed as an oncocalyx. Moving on to ureteric narrowing. So common sites of normal common sites of ureteric narrowing are at the uretropelvic junction, at the point where the iliac vessels cross the ureter, and at the vesicoureteric junction. So common causes of ureteric narrowing can be stricture, which can be iatrogenic, or it can be due to infective or inflammatory cause, or it can be a malignant stricture, or it can be a post-RT stricture, post-radiation stricture. So, or it can be ureteric narrowing can also be due to extrinsic mass which is compressed in the ureter. So coming to differentiating between a benign and a malignant stricture, often it is difficult to distinguish between a benign and malignant stricture because there is some significant overlap. So there are certain clues which can help to differentiate between a benign and a malignant stricture. One is of course the history. For example, history of post trauma or a post radiation. And next is the location of the stricture, often on multifocality of the strictures. So if there are multifocal strictures, it raises suspicion of a transitional cell carcinoma. And other findings like synchronous involvement of kidney or bladder. For example, as we discussed previously, synchronous in TB, the tuberculosis, there can be synchronous involvement of the kidney. So here we see a benign stricture with abrupt transition at the ureteric site, at the site of ureteric narrowing with proximal dilatation. So here we see a malignant stricture. So a filling defect is seen in the ureter with dilatation of the ureter below the filling defect. So this is commonly seen in slow-growing lesions. So this is typical of a transitional cell carcinoma, and it is described as a goblet sign or a chalice sign. So here we see a irregular narrowing of the ureter, with multiple mucosal irregularities. These findings should raise a suspicion of a malignant stricture. So here we see bilateral enlarged kidneys and multiple well-defined radiolucent filling defects, which are nothing but multiple cysts. So this has appearance is similar to the appearance of the Swiss cheese nephrogram. This is classically described in autosomal dominant polycystic kidney disease. So coming to the medullary sponge, some rare pathologies of which can be seen on IVU, medullary sponge kidney. So it's nothing but the ectasia and dilatation of the collecting ducts of the renal papilla. So what we see here is there will be linear striated collections of contrast material in the dilated contrast-filled tubules. So we see that there are dilated contrast-filled tubules within the renal pyramids, and this is the IVU image showing the linear striated collections of contrast material in the renal pyramids. So this is described as a paintbrush appearance, and as the disease progresses, there will be, because of stasis, there will be development of calculi in these dilated collecting ducts. So this leads to medullary nephrocalcinosis. So here we see that the bilateral pyramidal calcification. This is a CT image showing bilateral medullary pyramidal calcifications. This is typical of medullary nephrocalcinosis. So coming to bladder pathologies. So normal bladder wall thickness is less than 3 mm in a well-distended bladder. So we call it pathological if it is more than 5 mm in a non-distended bladder, and if it is more than 3 mm in a well-distended bladder. So the common causes of bladder wall thickening are can be a tumor like neurofibromatosis, or it can be due to infectious or inflammatory cystitis, or it can be a neurogenic bladder or a bladder outlet obstruction. So in this image we see in this prevoid image, we see a distended bladder with wall thickening more than 5 mm, and we see an irregular outline of the bladder. So this is suggestive of cystitis. And in this image, in the second image, we see a elongated bladder with diminished capacity, and we see an irregular contour of the bladder with multiple trabeculations. So this is called as a Christmas tree or a pine cone appearance, which is classically described in a neurogenic bladder. So coming to the importance of post-void image, post-void image is useful to evaluate patients with the upper urinary tract dilatation. So there is persistent dilatation of the pelvic calygeal system on post-void image suggests a fixed obstruction. So in this 10-minute image, we see that the renal pelvis is significantly dilated, whereas even in a post-void image, the renal pelvis is progressively getting more dilated compared to that of the 10 minutes image. So this is suggestive of a fixed obstruction. Also, post-void film is useful to assess the residual volume in patients with bladder outlet obstruction. So, coming to the end of the session, so the important things we have to look for in IVU are the SCOUT film. We have to look for calculi and calcifications. And next is anatomical variations of the kidney. As we discussed, we have to see the position of the kidney, the axis of the kidney, and size and contour, and function of the nephrogram. So the nephrogram should be bilateral and symmetrical, and there should be temporal sequence. The temporal sequence should not be altered. So first we see the density of the contrast in the nephrogram, and on a 5 minutes image, the pyelogram should be dominant. And we discussed about the abnormal nephrograms. So next we have to see the ureter. We are identify the scores, caliber, and look for any abnormal deviations. And urinary tract obstructions, if present, we have to grade the hydronephrosis and identify the cause of obstruction. And in bladder, we look for wall thickening, bladder volume, any abnormalities like diverticular, and post-void film, we have to look for bladder volume, residual bladder volume. So that comes to the end of session. Thank you, sir.
Thank you, Dr. Karthik. That was an extensive coverage of IVU. So, any questions? If there are no questions, then today's two talks were excellent, Dr. Ram Prasad and Dr. Karthik. Thank you for participating in our ultrasound primer course and enlightening the pages with your knowledge. Thank you so much. And thank you, the team, for giving me the opportunity.
Thanks to Dr. Madan Mohan for coordinating, and that's very nice. And we'll hand over to team Dr.